Hello, friends, and a warm welcome to today's 4D discussion. The 4D discussion is all about detail, discussion, and dialogue in patients with diabetes. And I think all of us in our clinical practice do have this situation where we deal with patients with heart failure, CKD, in the presence of backgrounds of diabetes, and the management often gets challenging. Many times in clinical practice, we do treat these patients individually. If we look at the individual disorders, we have individual guidelines from the American Diabetes Association for Diabetes Management, American Heart Association from cardiology perspective, and the KDIGO guidelines that we have from a nephrology perspective. But where do these guidelines converge? I think that's the important topic that we are planning to discuss today, the guidelines for a management of a patient who's got CKD and heart failure in the presence of diabetes. I think really important to get perspectives from all the specialists, but at the end of the day, when we are managing the same patient from different facets, I think it's important for the treating physician to know the perspectives of a cardiologist, nephrologist, and endocrinologist. And I think, therefore, this particular platform is indeed really good and fruitful to discuss how the nuances for each of these specialties can be managed. Today, we will discuss a lot of questions, especially gaining perspectives, what these individually the guidelines tell us, but more importantly, where do they converge? What are the medications that are available? But more importantly, as physicians, what are the side effects that we have to be concerned about? And we'll also possibly discuss a real life case scenario where and how we have to manage these. And at the end, I would request our speakers to give us a crisp summary, a one-page checklist, if I may say, to carry home the message. So today, we are really looking forward to welcome our three panelists for today. We have our esteemed cardiologist, Dr. Atul Ghosh, who is an MD General Medicine and a DM in cardiology, currently consultant physician and interventional cardiologist at Globe Care Diagnostic Center and Polyclinics in Kolkata. We also have amongst us an endocrinologist, Dr. Monam Chattopadhyay, again, MD Internal Medicine and a DM endocrinologist, who's currently a consultant endocrinologist and diabetologist at NRS Medical College and Hospital in Kolkata. And we also have a nephrologist amongst us, Dr. Himadri Kole, again, DM in nephrology after his MD General Medicine, currently consultant nephrologist at Manipal Group of Hospitals in Kolkata. So a very, very warm welcome to all our three esteemed panelists from the City of Joy, from Kolkata. And thank you all for joining us. And we would have very important questions to be addressed. But before we do that, maybe one opening remark may I request from all of you. May I request Dr. Ghosh to start first?
Sure. Thank you, sir. So earlier in our days, we used to think that there is cardiological disorder, there are metabolic disorder, and there are renal disorder. So likewise, then came cardiometabolic syndrome, cardiorenal syndrome, renocardiac syndrome. But nowadays, we are understanding that the pathophysiological process, the vascular process, even at the genomic level, all these disorders, they converge. And now a new terminology is coming up, like the cardio-kidney metabolic syndrome, the CKM syndrome, or it may be called cardiorenal metabolic syndrome or CRM syndrome. So dapagliflozin is such a molecule which acts as the core of the pathophysiologic process that causes those cardiometabolic syndrome. And along the discussion, we will all come to know that the guidelines actually converge from different international and national bodies of Cardiac Society, Nephrology Society, and Endocrinology Society. All the guidelines actually converge regarding use of dapagliflozin in this disorder. Yeah.
Thank you so much, Dr. Ghosh. And may I ask Dr. Chattopadhyay to give your opening remarks?
Thank you, sir. Just as Dr. Ghosh has mentioned beautifully, that all these three entities form a continuum of a single disease process. As endocrinologist, what I can add is that day in, day out, we have to treat diabetic patients. And diabetic patients have all sorts of comorbidities like heart failure, ischemic heart disease, chronic kidney disease, so on and so forth. So for that, they have a plenty or plethora of medications, and they are at times, more often than not, very confused what medicines to take and what prescription to follow. So most of the times, the onus is on us to compile and assimilate all the prescriptions and guide the patients properly along with the diabetes medicines per se, and the proper lifestyle through which a diabetic patient could lead a metabolically healthy life, so that these complications can be mitigated. So for that, we need to be aware of all the guidelines and bring them into a same podium.
Very well said, Dr. Chattopadhyay. And yes, I think all of us in clinical practice do see a patient, the same patient, having problems with the kidney, problems with heart failure, and underlying diabetes, and how to address all of them. We look at guidelines, there's different guidelines, and how does this converge is what we're looking forward. Also, welcome Dr. Kole, and if you'd like to add another opening remark from your side.
Thank you, sir. So, as already mentioned, that we are in the era of CKM, that is cardio-kidney metabolic syndrome. So we have drugs like the RAS inhibitors, we have SGLT2 inhibitor, the non-steroidal MRAs. So where we as a nephrologist stand in this cardio-kidney metabolic syndrome, that whenever there is kidney dysfunction, you can say chronic kidney disease, CKD, it alters many things like the pharmacokinetics of the drugs we use. Then it increases the chances of congestion, where we get increased afterload. And the drugs we use, that is a RAS inhibitor or the MRAs, we'll be discussing later. So it increases the risk of hyperkalemia. The hyperkalemia risk is increased in presence of CKD. So as a nephrologist, we have to adjust the doses of the drugs, and we have to see whether when it is to be stopped or discontinued temporarily. So this is important for us. Thank you.
Absolutely, very well said. And yes, I think renal adjustment of drugs is important, making sure that they are not interacting amongst themselves, what the impact they are having on the electrolytes, that needs to be monitored. A lot of things from a nephrology perspective as well. So friends, I think we all agree, we are all on the same boat to tell that today when we talk of patient care in people with diabetes, we're just not looking at glucose control. We're looking at the same patient from different point of views, from a cardiologist, from a nephrologist, and from an endocrinology point of view. But we do need to manage the patient in an aligned way, and with given guidelines, AHA from cardiology point of view, from KDIGO from kidney point of view, and ADA from the diabetes point of view. And in addition, we have our Indian versions of these guidelines as well. We need to converge somewhere, and that's the important point that we're going to discuss. And let's start with the discussion, and maybe to begin with, where do our guidelines converge? If I may ask Dr. Ghosh, to give us a brief pathophysiologic brief as to what you would say as to when we are dealing with such a patient with a problem with the kidney, problem with heart failure, in the underlying presence of diabetes.
Sure, sir. So as we all know from our childhood days that heart failure, there is actually an equilibrium between three important axes: the sympathetic nervous system axis, the renin, angiotensin, aldosterone axis, and also the neprilysin axis. So it is a beautiful interaction between all the three axes, which maintains the heart at the steep axis of the Frank-Starling curve. So when those axes destabilizes, patient goes into decompensated heart failure. We all know about the basic pathophysiology of heart failure. Now, when it comes to diabetes, it causes microvascular injury, it causes myocardial metabolic alternate, and that's why diabetes is a very important cause for not only ischemic heart disease, but it also causes diabetic cardiomyopathy, and it also predisposes worsening heart failure, which is very important cause for mortality and morbidity of our heart failure patients, which are otherwise maintaining well on current GDMT. We all know the four pillars of GDMT. And also, during all the same axis, the renin, angiotensin, aldosterone axis, the sympathetic nervous system, the hypertension, all can combinedly cause renal injury. And the hemodynamic abnormality that is perpetuated by the heart failure and the heart failure patients and diabetic per se, all those in a combined way, they act on the kidney and cause harmful damage. So we can see that diabetes, heart failure, and renal damage all are actually a vicious cycle. They act in a vicious cycle manner. So guidelines need to converge in such a way that it somehow breaks the cycle between the heart failure, kidney injury, and diabetes. And in that way, dapagliflozin acts in a very important way. Yeah.
Thank you for that. And thank you for very clearly mentioning that all the three problems are not only linked to each other, but they, as you rightly said, are in a vicious cycle. One enhances the other, and it starts becoming very challenging to address each of them individually. We need to look at the patient much more holistically. If I may move on now to Dr. Chattopadhyay and ask about the pivotal role of an endocrinologist when they are seeing such a patient, what would be the thoughts that come to your mind when you're having a patient with diabetes, CKD, and heart failure? We focus on glucose, but overall now we are just not looking at that alone. So what are your comments on that?
Yes, actually, managing a patient with type 2 diabetes mellitus complicated with advanced heart failure or CKD becomes very troublesome, because one way or the other, one problem perpetuates the other. So at a time, heart failure and CKD makes diabetes management very complicated and difficult. On the other hand, uncontrolled hyperglycemia and ongoing microvascular damage leads to acceleration of different macro and macrovascular sequelae, including heart failure and diabetic nephropathy. So we need to take care of both the arms, and there is some restrictions so far as use of different anti-diabetic medicines are concerned, with declining EGFR in CKD that need to be taken into consideration. On top of it, certain medications we cannot use in advanced stages of heart failure due to fluid retention, like pioglitazone and so on. And certain medications which have proven cardiorenal benefits in different cardiovascular and renal outcome trials that need to be added, as Dr. Ghosh has mentioned, that SGLT2 inhibitor and GLP-1 receptor analogs must be a part and parcel of the treatment armamentarium. So I think these are the points that are very, very important when it comes to treatment of such a patient.
Completely agree. And I think nephrology is also quite centrally placed in the management of these patients. Dr. Kole, what are your thoughts? How is nephrology centrally placed in care of these patients?
Well, as I said earlier, that renal dysfunction, chronic kidney disease, alters the pharmacokinetics of the drugs and also the tolerability of the drug, and it increases the chances of the adverse event. For example, the hyperkalemia. The chances are more in presence of CKD with the RAS inhibitor, the ARNIs, and the non-steroidal MRAs. And one more thing I want to elaborate, that we check albuminuria. So why it is important? It is not just important from the nephrological point of view. It is also important from the cardiological point of view as well, because microalbuminuria, or you can say albuminuria, it reflects generalized microvascular and endothelial injury rather than just isolated glomerular damage. So the changes in albuminuria, it keep in track with the changes in the cardiovascular risk. That is also important. So the nephrologist integrate the kidney preservation strategies with the heart failure stabilization. So with balancing all the drugs and the glucose lowering therapies while protecting the EGFR and avoiding hyperkalemia.
Completely agree. And I think this is something which is really important to monitor when our patients are being managed with all these conditions. So absolutely well placed. But now I think all of us in our individual fields are very well placed and know our guidelines very well. But let's hear about our individual guidelines from each of our specialists. And maybe I go back to Dr. Atul Ghosh first. What would be your message from the guidelines, the HA guidelines? When we have a patient with all the three problems, which are the drugs that come on top of your list?
Sure. All the bodies of cardiology, be it AHACC or ESC, even our CSI guidelines. So we have in heart failure patients, we have a special set of 4 pillars. The legendary 4 pillars. One is ARNI, one is SGLT2 inhibitor, one is beta blocker, and one is MRA. And now the 5th pillar is coming, that is vericiguat. So what guidelines say that each guidelines we divide heart failure into three categories actually according to ejection fraction, as we all know: heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and heart failure with mid-range ejection fraction. So in case of HEPREF, as we all know, heart failure with reduced ejection fraction, there are four pillars of therapy, well-established group of therapy, all are class 1 indication. In case of HEPREF, the guidelines differ quite a bit because we have very few drugs which are effective in heart failure with preserved ejection fraction. So what guidelines say that when we get a patient with heart failure with preserved ejection fraction, first of all, we have to look at the risk factor. That is most important. We have to eliminate the risk factor, be it ischemic heart disease, or most important is hypertension, and most importantly nowadays we know obesity. Earlier it was thought that obesity is a passive risk factor, but now we all know that obesity is a very, very active risk factor. The adipose tissue is not an inert tissue, it is very active tissue which contributes to the heart failure continuum. So we have to address hypertension, obesity, and ischemic heart disease. And the only drug which has got a class 1 recommendation is SGLT2 inhibitors, be it DAPA or IMPA, anything. And some evidences are there for spironolactone or MRA, and few trials supports especially in case of ejection fractions below 57% for ARNI. So what does guidelines say from our point of view? When you get a patient with heart failure, practically we have to screen them for underlying comorbidities, be it renal deterioration, be it diabetes, and we have to combine, as Dr. Chattopadhyay says, because the pill burden becomes very high, even 10 to 14 drugs. So it has become very difficult for patients to take. So we have to combine, we have to take a holistic approach for each patient. So only few drugs which acts as heart failure, diabetes, and also the chronic kidney disease continuum are the one SGLT2 inhibitors. They act very good. One is ARNI, ARNI and angiotensin receptor neprilysin inhibitors, or the RAS blockers. And another one is non-steroidal MRA, that is finerenone. It is very good in alleviating the renal damage, and also that is associated with diabetes and heart failure. The recent heart failure trial is also going on. Probably it will come out as a very good result. So these are all very good drugs which acts as the vicious cycle that I have mentioned between the heart failure, diabetes, and chronic kidney disease.
Absolutely. I think you've beautifully listed all the different classes of drugs that are important. And I think all our guidelines would kind of, say the similar number of drugs. But, specifically when we manage diabetes, and Dr. Monam, if I may ask you, what would be your individualized glycemic management plan for a patient when we have all these three? Yes, we have these drugs that Dr. Ratul mentioned, but what would be the important points you as an endocrinologist would be looking in terms of diabetes management of these patients?
Thank you, sir. Dr. Ghosh has beautifully and comprehensively covered most of the aspects of therapy, disease-modifying therapy in terms of heart failure patients. As an endocrinologist, when we particularly deal with patients with type 2 diabetes mellitus with established atherosclerotic cardiovascular disease or prone to high risk of ASCVD or developing CKD, so the first thing that comes to our mind is the addition of SGLT2 inhibitor. SGLT2 inhibitors have been recommended in most of the guidelines, like the ADA and AAC for us endocrinologists, for the KDIGO for the nephrologist, and also the AHA-ACC has just been mentioned by Dr. Ghosh. So there have been robust data in terms of reductions in heart failure for hospitalization, for CKD progression, albuminuria, cardiovascular mortality, all-cause mortality, so on and so forth. And we also reduce the insulin and the insulin secretagogue dose, particularly when we add the sulfonylurea, because it is also a potent HbA1c lowering drug. Coming to the second important point, that as Dr. Ghosh has mentioned, that obesity is another very important risk factor. So in this vein, I want to highlight the importance of GLP-1 receptor agonist. The ADA and ESC guidelines both have recommended the GLP-1 receptor agonist in particularly patients with established ASCVD or patients prone to high risk of ASCVD. they actually augment or rather complement the disease modifying effect of SGLT2 inhibitors, particularly in patients with obesity, heart failure with reduced ejection fraction, preserved ejection fraction, particularly those with high body mass index. In addition, we have to take care of the RAS inhibition in terms of AC inhibitor ARB, ARNI therapy as the foundation therapy. In cases of albuminuric CKD, AC inhibitor and ARB are the first line option. So after optimal management with AC inhibitor ARB for accrual of additional benefit in terms of albuminuria, we can add non-steroidal mineralocorticoid agonist like finerenone, as Dr. Cole has already mentioned, keeping due concern about regular monitoring of the potassium. So in heart failure and CKD patients, all these drugs are to be used with a caution and very judiciously, and for particularly elderly patient and end stage renal patients or end stage heart failure patients, there is a concern of hypoglycemia that has to be kept in mind. Particularly in advanced cases, there is also hypoglycemia associated autonomic failure, which perpetuates more and more hypoglycemic events, which becomes very difficult for the patients. So for them, the insulin and secretagogue should be used very cautiously, and in selective cases, we can take help of the CGM or AGP to detect the appropriate timing of hypoglycemia and individualize the therapy. We should be lenient so far as the HbA1c target levels, particularly in patients who are elderly, who are frail, who have several comorbidities, and who are more prone to have hypoglycemia. In cases of advanced CKD or anemia, the marker for overall glycemic control in places of HbA1c, we should consider doing fructosamine assay. So these practical things, I think, should be kept in mind, particularly in managing such cases. And these are also evidence-based so far as the real-world evidence and also the randomized control trials and recommendations from different august bodies are concerned.
Yeah, so I think that was very well summarized, and especially mentioning, about the special populations in diabetes. And we definitely have these different classes of drugs, but often a challenge in clinical practice. And I request Dr. Collier to address this, from a nephrology point of view. How do we sequence the use of these drugs in clinical practice? Now, we are very clear. We've heard from Dr. Ghosh and Dr. Chattopadhyay. We have these 4 or 5 classes of drugs which are helpful in these patients. But for a given patient, we are not going to be starting all of them. So in nephrology practice, what are the pointers you're looking at, and how do we sequence these particular medicines? Dr. Kohli.
So first of all, I want to mention that we have a number of drugs in our hand, but whenever we see the patient for the first time, say I'm giving an example. Say for example, a patient is admitted in a hospital with a renal dysfunction in a state of fluid overload. So in that case, we should not be starting these disease modifying drugs because the GFR is not stable. Maybe the potassium is on the higher side, or the creatinine is say elevated. So we don't know the baseline creatinine. We don't know whether this is AKI or a stable CKD. So we should refrain ourselves from adding this SGLT2 inhibitor or ARB, ARNI, or non-steroidal MRAs. So we should manage the acute state, and these drugs should be added at the time of discharge. So because often we see that as soon as the patient gets admitted, one of these drugs are started, and the patient develops drop in the GFR or hyperkalemia. So that is important. So first of all, we should assess the baseline status of the patient. We should check albuminuria, as I already said, that importance of albuminuria, the serum potassium, the acid-base status of the patient, and more importantly, volume status. So when a patient is in volume overload, if we start diuretic along with SGLT2 inhibitor or ARB, there is more chance of developing AKI and electrolyte disturbance. So the patient should be decongested first, then we should start the disease modifying therapy when the GFR is stable. So from the nephrological point of view, SGLT2 in a patient who is diabetic with CKD, SGLT2 inhibitor is the first choice unless contraindicated. And of course, we should counsel the patient about the infection, UTI, and the genital infection, and the expected initial eGFR dip or the rise in the serum creatinine. Then either we can start the SGLT2 inhibitor and the ACE inhibitor together, or in a step-by-step manner. So there is no clear-cut guideline on this. So I prefer to start one by one because of the risk of GFR dip. And we'll start with ARBs, and we'll up titrate if tolerated based upon the GFR, the blood pressure, and the potassium. And if the patient is in heart failure with reduced ejection fraction, then ARNI is preferred over ACE inhibitor or ARB. And if even after adding these drugs, if the patient's proteinuria is not controlled, then we can add the non-steroidal MRA in case of heart failure with preserved ejection fraction, and in case of reduced ejection fraction, aldactone is always preferred. And the diuretics to be optimized to avoid the prerenal AKI. And these patients are prone to develop hypoglycemia. So the nephrologist should coordinate with the endocrinologist for dose titration of the sulfonylurea if the patient is on, or the insulin. And potassium management, because we don't want to stop these important drugs, the MRAs, the ACE inhibitors, or the ARNI, because of hyperkalemia only. So dietary counseling is important, and careful titration of the RAS inhibitor, MRAs, and potassium binders whenever needed. So nowadays, Lokelma, that is the sodium zirconium cyclosilicic, has come. So this might help us to maintain these drugs as compared to the earlier days. Thank you.
Thank you, Dr. Kole, for that very crisp summary, but also really some practical pearls of wisdom, if I may say. We all know that these drugs are, but very wisely put as to which ones to be used in which patient profile. I think we have a really good experience now with SGLT2 inhibitors. We've all seen the clinical improvement. I think another important point that you highlighted was, which is important, not to just have a knee-jerk reflex looking at one high potassium and stopping these very, very important drugs, because we can reduce potassiums with other ways, and dietary counseling is something that really reduces it quite significantly within 24 to 48 hours if the patient starts avoiding. Many times patients are consuming high potassium rich foods, which are they're not even aware that that is the incriminating factor there. So very, very well said. Having said that, I think cost does rule the Indian market quite a lot, and our experience with GLP-1 RAs may not have been as much as SGLT2 inhibitors, but now with them going off patent in a couple of weeks from now, I think utilization in Indian scenario would also be good and very well placed, as mentioned by all three of our experts. So thank you, Dr. Kole, for that. And I think now we know about the drugs. We've listened about how we practically sequence these drugs, but I think what I'm really now moving on to, and maybe I'll ask Dr. Ghosh about this, about safety and monitoring of these drugs, as to what are the important points the treating physician has to keep in mind, and especially from a cardiologist's perspective, what would you say?
Sure, sir. So whenever we get a patient admitted in our wards with decompensated heart failure with diabetes and nephropathy, the first and foremost priority for us is to decongest the patient. So we have to assess volume status very regularly, both clinically and objective way. Clinically by improvement of shortness of breath and improvement of orthopnea. Objective way by measuring the weight and assessing the JVP and basal Krebs and fetal edema, as we all know. And second most important thing, we have to measure the vitals, the blood pressure, the urine output, because blood pressure maintaining BP and end organ perfusion is very important in decompensated heart failure patients with multiple comorbidities. And we have to measure the renal parameters, the creatinine, potassium. We have to measure it very importantly. And we have also, in case of such multi-organ failure patients, measure CBG very regularly, because often we come to know that patients have underlying low count sepsis, very important. A patient of decompensated heart failure with total leukocyte count around 9,000 to 10,000, they are having sepsis, and those patients are very prone to develop hypoglycemia in context of heart failure and CKD. So volume status, electrolytes, kidney function, and glycemic checkup. These are all very important parameters to be followed in inpatient and also in case of outdoor patients.
Very well said. So I think as doctors, as specialists, I think our responsibility first is to do no harm. And I think Dr. Ghosh has very clearly mentioned, the safety parameters that we keep in mind. And I think they're common for an endocrinologist, cardiologist, and a nephrologist. All of us need to keep this in mind. Maybe I'll ask Dr. Chattopadhyay now, certain special endocrine scenarios, when we deal with these patients who've got heart failure and CKD in the presence of diabetes, maybe 3 common scenarios if I pick up from clinical practice. What would be your comment for people who have advanced CKD? How would your priority for drugs change? What would the points, that come to your mind in your prescription when you're dealing with such patients? So advanced CKD, maybe GFR of less than 30.
Yes, the most important aspect that I want to highlight that SGLT2 inhibitors should form the crux of anti-diabetic management, and all guidelines converge into recommending SGLT2 inhibitors. So previously SGLT2 inhibitors were recommended till an eGFR of 30, but recent data and dedicated renal outcome trials have shown us that dapagliflozin and empagliflozin could be used till lower eGFR, say to the tune of 20 to 25. Another important scenario or or treatment dilemma that we see that after initiation of SGLT2 inhibitor in a diabetic kidney disease patient, there is an initial drop in the eGFR. So at times we are quite confused that whether to continue SGLT2 inhibitor or stop it altogether, because it's contraindicated or not recommended below an eGFR of 20. So the teaching is that even if you start an SGLT2 inhibitor and eGFR drops down, you continue with the therapy because it will ultimately revert back to normal unless the patient lands up in dialysis or renal replacement therapy. So that is so far as the SGLT2 inhibitor is concerned. Another important aspect already highlighted by our renowned nephrologist colleague Dr. Kole is that albuminuria. So beyond SGLT2 inhibitor and adequate RAS inhibition, if there is still room for adequate control of albuminuria, because albuminuria is not only a risk factor for ongoing kidney disease but also a risk factor for cardiovascular mortality. So that needs to be taken care of very aggressively. So for that, finerenone or non-steroidal mineralocorticoid receptor agonist is a very important molecule. And one important caveat of initiating finerenone is, number one is the eGFR and proper tailoring of the dose, and secondly the potassium level. And potassium, as you have already mentioned, that it is a very sensitive test, and it is often the result is fallacious because of improper sampling of the blood, improper assay technique, or even the diet that the patient is consuming. So potassium report has to be analyzed very judiciously, taking in consideration all these aspects. And last but not the least, in CKD there is a very important concern for hypoglycemia, because the patients are at higher risk of low blood glucose levels. So for that, the insulin that is often part and parcel of the treatment of the advanced diabetic kidney disease patient, that needs to be titrated very cautiously with regular SMBG, preferably a CGM at times if possible. And the insulin secretagogues and other drugs, if they are used like DPP4 inhibitors like linagliptin, so they have to be used very cautiously. So far as the sulfonylurea is concerned, the sulfonylurea with the lowest propensity to cause hypoglycemia that are chosen, like glyclazide or glipizide in cases of glimepiride, although none of the molecule is contraindicated, but they have to be used with caution. And moreover, adequate dietary counseling, weight management, sleep apnea counseling, physical activity prescription, management of other comorbidities like hypertension, dyslipidemia, we should not forget about all this. So we should prescribe a holistic treatment regimen to the patient to gain the maximal benefit.
Completely agree. And maybe just two other quick scenarios, Dr. Chattopadhyay. Patients with obesity and those who are elderly, what would be the special considerations?
Yes, particularly in obese patients, I think GLP-1 receptor analogs, because they are very soon becoming off patent, so they they need to be considered as a part of the treatment regimen, and proper diet and lifestyle modifications that are also emphasized time and again. For elderly patient, I think the risk of hypoglycemia is quite higher when managing the as compared with the younger patients. So the target HbA1c for a younger patient, if it is near about 6.5%, for elderly and advanced CKD patient, the target HbA1c should be more lenient. It should be around say 7.5 or even rather 8%. So our main objective is to prevent hypoglycemia rather than very strict glycemic management.
That's right. So I think with this, we've got a fair idea about usage of these drugs and talking about their side effects and in special populations. And maybe I move on to Dr. Kole now. Trying to discuss a case maybe in patients with diabetes that we see, and maybe a case scenario, which is a common case scenario that we see in clinical practice as to how we would optimize the treatment. So if I may ask about, suppose a patient who's 72 years old, a lady who's got type 2 diabetes, maybe heart failure, even though the ejection fraction is normal, CKD stage 3, and albuminuria with hypertension on ACE inhibitors and loop diuretic already. So what would be your approach from a nephrology point of view?
So to summarize, we have an elderly female who is diabetic, hypertensive with a heart failure and preserved ejection fraction and CKD stage 3B. And the patient is already on ACE inhibitor and a loop diuretic. So from nephrology point of view, we'll start with the SGLT2 inhibitor first, if not contraindicated, and counsel the patient about the expected GFR dip or rise in the serum creatinine. So whether we'll maintain with the ACE inhibitor, we will check the labs, that is serum creatinine and potassium after 1 week. If the rise in the serum creatinine is within 30% of the baseline, then we'll continue with the SGLT2 inhibitor. And if there is persistent albuminuria, then we may add finerenone with scheduled potassium checks at 1 week and 4 week. If the patient maintains normocalemia, then we can continue with the finerenone. And again, here we have to adjust the diuretics, as I said earlier, to optimize the volume status and avoid pre-renal AKI, as the patient is already on SGLT2 inhibitor and ACE inhibitor. So the risk of AKI is higher when a diuretic is used. So as soon as the patients are offloaded, we have to reduce the diuretic, and we may have to stop diuretic if required. And as Dr. Monam has already told regarding the risk of hypoglycemia, and we have to avoid sulfonylurea or use sulfonylurea with a lower propensity for hypoglycemia.
Agree. And I think we've got really good perspectives from all the three specialties here. And I think before we close, maybe a good one-page checklist or a quick carry-home points, if I may get from all our specialists, maybe starting from Dr. Atul, then Dr. Monam, and then Dr. Kole. So Dr. Ghosh, when we are dealing with these patients, for all our viewers, what would be your quick checklist that you would suggest our viewers to remember?
Sure. So when we get a patient of heart failure with diabetes mellitus and CKD, so we should screen for heart failure in all T2DM and CKD patients with symptoms or elevated NT-proBNP level. We should initiate SGLT2 in early eligible patients because SGLT2 inhibitors are only one agent, a single agent that is expected to be used, that is eligible across all the spectrum of ejection fraction. So we should use ARNI in symptomatic heart failure with reduced ejection fraction patients whenever possible, because it has got the huge life CV benefit. So we should add beta blocker, MRA, be it steroidal or non-steroidal, and consider finerenone for T2DM and CKD with proteinuria. We should consider GLP-1 receptor agonist with ASCVD and obesity risk. We should monitor EGFR and potassium creatinine at regular intervals. We should coordinate with our endocrinology and nephrology colleagues for a very complicated patients for a holistic approach. And we all, most importantly, we should educate our patients for what after discharge, their potassium level check, their creatinine level check, their regular follow-up, and not to discontinue their medication on their own. Yeah.
Right. So I think with this, we come to an end of our session today. And thank you all for joining. And I hope our viewers have had a very fruitful output and learning from today's discussion. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir.